Welcome to another special edition of At the Table with CAHSAH. As we explore California's hospice emergency regulations, my name is Mark Wilson. And once again, California hospice providers are facing one of the most significant regulatory changes our industry has seen in years. And through these special podcast airings, although they don't really air, I guess they appear digitally. Anyway, we're breaking down the new California hospice emergency regulations with the experts who know them best so that your organization can prepare right now. So today we're going to focus on two of the most talked about requirements in the new regulations, those being nurse-to-patient ratios and patient acuity system. We're going to go through the basics today on this podcast, and then please go to CAHSAH.org and register for the webinar where our experts drill down a lot further, and you will have an opportunity to ask actual questions and get actual answers. So joining us once again are two nationally respected hospice experts, Cindy Hatton and Eric Peterson. Welcome to you both again.
Hey, great. Thank you for having us,
Good
Mark.
to
Great to
see
be
you.
here.
Yeah, so let's, if we could, let's start with the big picture thing again, and I'll put this out there for either one of you. What problem are regulators trying to solve in placing so much emphasis on the nurse ratios and patient acuity?
I'll
Cindy?
take it.
Yeah,
I
Cindy.
think that when they were doing their investigation, they found nurses that had caseloads of 20 or more, and felt like that was too many. That they were unable to manage the care of those patients with that many patients, because some of them are acute, some of them are actively dying. So you've got some that are very sick, and then you've got some that you've got under control. So the number really needs to be based, and that's why it's sort of a two-step thing. They gave us a number, but they also gave us acuity, which really drives what the patient load should be, or caseload should be. If you've got, a caseload and you've got many patients who are pain out of control or symptom out of control, and you're going every day or sometimes twice a day to change medications and make sure that, we're getting on top of it, then yes, they can't have a big caseload when they have that much intensive care that they need to do to a patient.
So I know enough to be dangerous. Can someone talk to me about the 12 patient ratio? Is that such a thing?
Yeah, so I mean, Cindy really articulated it well. I mean, we kind of have in this nursing section sort of two different items that are really being asked of it. The ratio is a monitoring system that's going to look at ultimately your direct care staff that is hired to provide direct care, right? So can include RNs and LVNs, and you have to be limited to 12 patients per individual. Uh, nothing really kind of outlines how you're assigning them and naming them. And I think that's where a lot of folks in our industry are struggling right now is well, I assign patients to my nurse case manager. I don't assign them to the LVN. So what are you really looking for, right? Or how do I really track that? They're giving you some flexibility, but the stipulation is it has to be staff that's hired to provide direct care. And so that 12-to-1 is sort of the ceiling. And then this patient acuity system, which is to predict the needs of the individual, should help to feed back and ultimately guide, your personnel and resources for the day or the night. And it may also influence caseloads. So we're trying to work through and tease out some of those finer nuances to say, well, what's allowed in the regs, what's expected in the regs, and ultimately what sort of system can you set up that for the intent of the regulations is to be successful. It's to predict staffing. It's to help support quality patient care and not have, like Cindy said, a nurse with 20 patients on her own with no LVN and they're all at end of life. That is a totally different population than 20 patients who, are Alzheimer's and, like just came on and are kind of doing pretty well overall, but in that last 6 month, trajectory. So a lot to work through and,
Yeah,
and a lot of clinical decisions to be made by the team.
I'm not a lawyer, okay, but I'm
Mhm.
going to think like one real quick, okay, if you don't mind, because
Yeah,
again, I
yeah.
read a little bit about this, and there are a couple things that kind of intrigue me. The proposed regulation talks about the fact that a nurse may be assigned no more than 12 patients. And my lawyer brain,
Mhm.
again, I'm not a lawyer, but I could have been one.
Yes, yes,
Um,
yes. Yeah.
what counts as an assignment, and do all patients count equally?
That's a great question.
Well, it means, according to their definition, assigned means a licensed nurse. It doesn't say LV, and then their definitions of licensed is an RN or an LVN, has primary responsibility for the provision of care to a particular patient within their scope of service.
Yeah.
And I think they put that in there like that because people, the scope of service of an LVN is very different than the scope of service with an RN. I think the language is confusing to hospice providers because
Yeah.
we do not think of it that way. That's not how we schedule and how we create our teams to take care of patients.
Mhm.
We call that nurse that is assigned, we call them the RN case manager. And so, that is who's assigned.
So
Yeah.
I know you're going to
And
be drilling down more on this on the webinar on next Wednesday, but do organizations need to be thinking right now about staffing differently in any way?
I would say it depends on how they're staffing now. If you're an
that's a
agency,
great answer,
that was a
non-answer,
good
Cindy.
answer.
Yeah.
I was still trying to be
Yeah.
a
I mean,
lawyer, and you
it's
completely got me.
I think the answer is yes. You got to
Y
be thinking about your staffing
Right,
and you got to be monitoring your ratio, I think at a bare bones minimum. Like start
right,
there, right? And then work, constructively with your
right.
clinical team to determine what is this acuity system and how might that influence this over
Right.
time,
And I
like
think that people who have caseloads right now and I've had these questions, people who have caseloads of 20 or 18, and they are asking, well, what if they go to 13? And what if they go to 14? And, the language, if you read in their sort of explanation, it does say 12 at one time. So we're working with CDPH because there are times when you have patients who are you have a caseload, 12, let's say 12. You have patients actively dying, you have patients being admitted. Well, you might be at 13 for a day or two or something like that. So, people want to know those questions, and we are still have questions out to CDPH. But if you're an
yeah.
agency who has typically your nurses carry, 18, 20 patients, then I would be looking at how you can get that number down to 12.
Absolutely, yeah, and that's where I think, the regs allow you to take into account the LVNs that you have. They haven't really, and this is where as an industry, I think we need to champion some clarity, like how do we address PRNs, where does that come into play, right? Like for volume, how, do you choose your night on call staff? Do you choose your admit nurses? They just tell you it's nurses assigned to provide direct care, right? So there's still some sort of clarifications I think that we need, but again, just the way that I would advocate that anyone looks at their staffing is to be conservative to make sure that we're meeting the needs of the patient, right? So that monitoring system can start with you just, maybe all your full-time, RNs and maybe all your full-time LVNs and see where your ratio's at. Um, Traditionally, it's kind of like 15 to 18 patients per RN case manager is what's sort of been out there in the industry standards. So this was odd that they picked 12, but then they allowed it to include LVNs, right? So when I've talked with my team, I'm kind of like, well, if we do 12, for an RN case manager and 12 for an RN case manager, the way we staff is we'll have an LVN kind of sit in between them. Well, that's really between the three of them, that's 36 patients. So you're at 18 per RN case manager at that math, but that's not how you have to set up your monitoring, and you don't have to do it each day. So like the time frame that they're expecting you to assess this. Is it daily? Is it weekly? Is it monthly? Is it annually? Like, those are all things that still aren't really specified. It's at the discretion of the agency for their policies and procedures to how to monitor and how to establish the review of that acuity system. So, in the end, I encourage everyone to do it right, and the more frequent, the better, but you have to also balance that with operational feasibility. You don't want to paint yourself into a corner to where you can't actually be successful with establishing these procedures, right, and executing them. So all of that is kind of what we're going to have to talk about in greater detail, in the webinar. And hopefully, as an industry, we can share resources and success stories to be able to come up with what would be a nice, sort of detailed clinical standard. That the regulations will never give you that. They're not going to give you an example, but there are a lot of bodies out there that are providing some examples, and ultimately, it's up to each company to create their own. So Cindy and I have had a lot of discussions. We talk about keep it simple, to start, and then figure out where and how you have to layer in additional details.
Yeah, I would
Cindy,
imagine
any other comments? Go ahead.
documentation is at maybe a whole other level. Again,
Right. Right.
Yeah,
I
yeah.
wonder, with patient acuity, do things change there, or do we have to be even more mindful? I mean,
Well, I think, you know what, Mark, I think about acuity when you read it. I mean, I think people who have been doing this for a long time, there's just a natural way you schedule patients and you think about patients. You've got patients, I always think of them in like three, and that's why we say keep it simple, three categories. You've got really pretty, and you don't want to use this word stable, but you have well-managed patients. You have some that are experiencing some symptoms, and then you have the people who are actively dying and transitioning. And so, when you're assigning patients and you've got a case manager, you're taking all those things into consideration when you're doing that. The thing that's interesting is there is no acuity system that has been developed and published for hospice. So we are going to be the cutting edge because there is none. And so people are scrambling, and, there are resources out there, and we're going to talk about that. We're going to talk about, for the nurses, the nurse ratio, we're going to talk about staffing models they can look at. And then we're also on the acuity. We've got some examples that they can look at, but they have to decide what works for their organization. And I think that is very hard for people because they want to just, okay, tell me how to do it.
well, that's one of the. It's funny.
Yeah.
That's one of the questions that I had. I was wondering if it was something I could just go purchase, or whether every organization is going to have to customize its own process. So thank you for that.
Yeah, I think customization is really what the regulatory body is like, giving you the allowances for. But I know that there's going to become a framework, of sort of a clinical or industry best practice or standard that will be developed through this. And ultimately, that's what I think will help to drive consistency, right, and care delivery. Um, but but each company just needs to make sure that they have something, and
Right.
that they're implementing something, and that they're monitoring it, and they have methods to see that it actually is accurately predicting. So, I think the clinical piece of what is the acuity system is going to be a nice clinical dialogue. The real hard work, at least in my mind's eye, and where I'm struggling personally, is like, well, how do I create a method to validate that it's accurate? So, I literally just left our first acuity meeting, as a committee. And, we have a couple different proposals of a very complicated clinical acuity system, um, and or a much more simplified acuity system. And at the end of the day, the more details, I think, in the acuity system that someone comes up with, maybe the better the research and the accuracy of that at some point. But you do run the concern of, like, what they call it, like inter-rater reliability. You might have two different people interpreting it differently, and now my method to assess it is more complicated because I got one nurse saying it should be this, and another nurse with the same patient population is saying, well, here's their acuity level. So to one nurse, it looks like it's okay. And to another nurse, they're underwater. So is it the acuity system? Is it the method to validate? Or is it the human who's actually caring for the people. Like, those are the challenges that our industry is going to be faced with, I think, in great detail. But, just take a step back, take a deep breath, monitor your nurse ratio, come up with a simplistic rate, acuity system, and then fine tune it over time. Like,
Right.
that's really, I think, kind of the and what's interesting in the regs, just to kind of throw it out there, Mark, is we talked about assignment, right? And does this influence assignment? Like, the acuity system is really unique in the sense that it says nothing in this acuity system will prohibit another nurse from caring for another patient regardless of who they're assigned to. So it's kind of like CDPH saying, like, yeah, it's supposed to influence your ratio, but at the end of the day, we just want you to take care of this patient. We
Right.
want you to meet the acuity and the needs of this individual. And how does this system drive that for day to day or night on call? And especially night on call, I would say, is something that you'll want to make sure maybe is a separate sort of vantage point or methodology to assess.
Yeah,
Cindy,
and
any
I
other
would I
thoughts?
would also add to that weekends. I think people forget
Yeah,
about weekends.
great point.
They
Yeah.
track our visits on the weekends, and so I think that people need to look at that because that's also when patients get into trouble is on the weekend. And they can't go from Friday to wait till Monday for something. So, that's when you get those, calls and people have to respond, and how does that work?
Yeah, absolutely. As we just
Okay.
talked about the 2-hour service response time, right? Requirements for geographical service areas. So yeah, it all
So I
comes
know
full
Eric's
circle.
got a hard stop here, and before we go, because I could go on, I could go on for hours with you guys. I really do. I get educated in these short little podcasts. I really do. It's a lot of good information. But the real information, the deep dive, is going to be at the webinar on Wednesday. So you want to go sign up for that. Um, but before we have to sign off here, could you guys once again just sort of give us an overview of what the takeaways will be in the webinar? We talked about a couple right now, but can you give us a sort of an
Yeah,
overview?
Cindy, go ahead and kick us off, please. Yeah.
I would say there's three areas. There is, first of all, we're going to talk about the language that's in the regulation. And I always say you have to know the regulation. You can't just interpret it your own way. So you have to look at the language and what the words are saying. And then we have the nurse ratio. And that we're going to go into different models and how do you look at that and how do you evaluate it. And then the third part is the acuity system. And here's some examples and what would, you can pick and choose from here to there. You don't have to start with a blank slate. You've got some examples that you can look at and it should help you.
Awesome. Any other
Yeah.
final thoughts, Eric?
You know, just to be mindful, there's some real specific details in the regs about how you document this, both for your committee meeting agenda and, who has to sign it and who's appointing it and all those other things. So, if I were to give any advice right now, to folks who are out there and maybe just learning about this, like, definitely look at your ratio for your staff. Join us on the webinar so we can bring to you some easy solutions on the documentation, the really detailed and sort of flexible clinical discussion on the acuity system. The more that we can all collaborate and share for questions or suggestions, the stronger that our industry in California will certainly become, and will help to set sort of the standard for the rest of the nation. So it's a great topic. It's, to me, the most important one when it comes to quality of care for the changes within our regulations. And it's something that all of us are going to need to embrace and determine, are we doing the right thing for our patients and how can we do it better? And I don't think any of us have gone into healthcare to not do what's right for our patients. So, as an industry, let's support each other through this, and let's certainly look to improve the quality of the care that we deliver.
Well, I got to tell you, once again, both of you, this has been another incredibly practical discussion. Even guys like me, an old business development guy, can understand a lot of the stuff you're talking about. So, I will tell you, today's episode, like all of them have been so far, they make things very clear. These regulations are about much more than just staffing numbers and that kind of thing. They're about demonstrating that every patient is receiving, as Eric said, the right level of care at the right time. And of course, we've only been able to scratch the surface today. So once again, please go to that. Please go to CAHSAH.org and register for all the webinars. It's a live educational webinar, by the way, where our experts, I think you're being joined by Annette Lee next week.
Yes, Annette, what we've been doing is we have sort of two primary presenters, but then like Eric will join us and Sharon will join us. And so, you sort of get a mix of us. But yes, Annette Lee will be joining us and she will be presenting. She would be here today, but she's on an airplane.
Yeah, I know she
Yeah.
is. I met her at the conference for the first time. She's a wonderful person, so I'm looking forward to getting her point of view. So
highly accomplished and incredibly insightful. She is a great instructor and very passionate about the industry as a whole.
The webinar is the place where they do the deep dive. This is just sort of a prep for you, so you can maybe get a couple of questions ahead of time. So register. Go to CAHSAH.org today. And if you know another hospice leader who would benefit from the conversation, call your competition up. We're all in the same business together. We're all doing it for the right reasons. So share it with them, and thank you again to both of you, Cindy, Eric. I sure do appreciate you. You're great to work with. My name is Mark Wilson, and thank you for joining us for CAHSAH's California Hospice Emergency Regulations special series. More to come. We will see you next time at the table, CAHSAH. Take care, everybody.